Your doctor looks at your blood pressure reading, 118/72. He smiles. Perfect, he says. But for you, at 73 years old, that number may not be perfect at all. It may be the reason you fell last winter. It may be the reason you feel foggy every single morning. And according to research published in the Journal of the American Medical Association, it may actually be shortening your life. I'm Dr. Julian Cross, cardiothoracic surgeon, 30 years in the OR. And today I need to tell you something that most doctors won't say out loud. The blood pressure target you've been chasing your entire life may be completely wrong for your age. By the end of this video, you'll understand exactly why that number was never designed for a body over 65, and what the research actually says your target should be. I'm also going to give you a simple 5-minute test you can do at home today, with no special equipment, that can tell you more about your real cardiovascular risk than most standard office visits. And I'll give you 3 specific questions to bring to your next appointment. Questions that could change the conversation and potentially the next 10 years of your life. Stay with me. This one matters. Let's start at the beginning. Where did 120/80 actually come from? Most people assume this number was discovered through decades of careful research on older adults. Thousands of patients, years of follow-up, rigorous studies of aging bodies. The truth is a lot less reassuring than that. The 120/80 standard was largely established through studies conducted on middle-aged adults, people in their 40s and 50s, healthy, active, with relatively flexible arteries. For that population, the guideline made sense. Lower pressure, less strain on vessel walls, fewer heart attacks. The logic was sound. The problem is that medicine took that number and applied it to everyone universally, regardless of age. And for decades, almost nobody seriously questioned it. So when your doctor says, we need to get that down, he is using a ruler built for a completely different body than yours. So what actually happens to your arteries after 60? Here's what changes, and it changes whether you like it or not. After 60, your arteries gradually lose their elasticity. They become stiffer. Think of a brand new garden hose versus one that's been sitting in the sun for 15 years. The old hose doesn't bend as easily. It doesn't absorb pressure the same way. Stiff arteries mean your heart has to work harder to push blood through. That naturally raises your resting pressure. This isn't a disease, it's biology. And here's where it gets critically important. Your body has pressure sensors built into your blood vessels. They're called baroreceptors. In a younger person, these sensors respond almost instantly. You stand up. They detect the shift. They adjust. Blood keeps flowing to your brain without any problem. After 70, those sensors slow down. The response time increases. And if your blood pressure is already sitting at the low end, there simply isn't enough pressure in reserve. That is not a side effect. That is a physiological reality. And it has consequences that most people are never told about. Before we go further, ask yourself this. Have you ever felt dizzy when you stood up too quickly? Have you grabbed a door frame just to steady yourself? If the answer is yes, keep watching, because what comes next may explain exactly why that's been happening. In 2019, researchers published findings in the Journal of the American Medical Association that should have made headlines in every doctor's office in the country. It didn't, but it needs to be in yours. The study looked specifically at adults over 75, not middle-aged patients, not theoretical models, real older adults, followed over time with real outcomes measured. And what they found was striking. For people in this age group, the optimal systolic pressure, that's the top number on your monitor, was not 120. It was between 130 and 145. Let me say that again because it matters. 130 to 145 millimeters of mercury. That is where older adults had the best outcomes. Fewer hospitalizations, better cognitive function, lower overall mortality. Not 120, not 115, higher than that. Now, I want to be completely clear about something. This does not mean high blood pressure is suddenly good for you. Uncontrolled hypertension, numbers above 160, 170, remains dangerous at any age. We are not throwing the rule book out entirely. What we are saying is this: there is a range that is too low for an older body to function safely, and millions of people over 70 are being medicated into that dangerous zone without knowing it. Does your doctor know your specific target range? Have you ever had that conversation? Write your systolic number in the comments below. I read every single one. Here is the statistic that stopped me cold when I first read it. Adults over 75 who are treated aggressively to reach targets below 120 have a 28% higher risk of serious falls and fractures. 28%. Think about what a serious fall means at 75 or 80. We are not talking about a bruise. We are talking about a fractured hip, a head injury, weeks in hospital. And for many older adults, a fall like that is the beginning of a very rapid decline. Here's the cruel irony. Doctors prescribe blood pressure medication to protect the heart and prevent strokes. A completely worthy goal. But if the medication drops pressure too far, it increases the risk of a fall. And a fall at that age can cause exactly the kind of trauma that causes a stroke or kills the heart. The medicine meant to protect you creates the very danger it was trying to prevent. And here's what makes this even harder to catch. The fall doesn't happen in the doctor's office. It happens at home. At 6 a.m. when you get up to use the bathroom. Your blood pressure drops 15 points before your baroreceptors have time to respond. Nobody connects it to the medication. It goes in the chart as mechanical fall, patient tripped. It wasn't a trip, it was a pressure problem, and it was preventable. Let's talk about what actually happens inside your body when blood pressure drops too low, because understanding this changes everything. Your brain is the most demanding organ you have. It makes up roughly 2% of your body weight, but it consumes about 20% of your total blood supply every minute without interruption. The moment that supply drops even slightly, the brain starts sending distress signals. In a younger person with flexible arteries and fast-responding baroreceptors, small pressure drops are corrected almost instantly. The body adjusts. You never feel a thing. But in a body over 70, your arteries are stiffer. Your baroreceptors respond more slowly. And if your resting pressure is already sitting at 115 because of medication, there is almost no buffer left. You stand up. Gravity pulls blood toward your legs. Your pressure drops momentarily. In a young person, the body compensates in 1 to 2 seconds. In an older person with low baseline pressure, that drop can last 5, 6, 7 seconds. During those seconds, your brain receives less blood than it needs. You don't necessarily faint. Most people don't. Instead, you get a brief moment of dizziness, a slight darkening at the edges of your vision, a feeling of unreality that passes in a few seconds, and that you've probably learned to ignore. Sound familiar? Here is the part most people never hear. That process, repeated every morning, every time you stand up dozens of times a day, is not harmless. Emerging research increasingly links chronic, low-grade underperfusion of the brain to accelerated cognitive decline in older adults. Your brain is not getting enough blood consistently, and over months and years, that has consequences well beyond just dizziness. So when your doctor says your pressure looks great, ask yourself, does your head feel great too? I want to give you a list, and I want you to be honest with yourself as you hear it. Do you feel dizzy or lightheaded when you stand up from a chair or get out of bed? Do you feel unusually tired in the morning, even after a full night of sleep? Do you sometimes feel like your thinking is slower than it used to be? Words take a moment longer to come. You lose your train of thought mid-sentence. Do you occasionally feel weak in the legs for no obvious reason? Have you had moments where you felt like you might faint, even if you didn't? If you check 2 or more of those may not be signs of aging. They may be signs of over-medication. I see this pattern constantly in patients referred to me after cardiac events. We go back through their history and we find it. Blood pressure beautifully controlled at 116, 114, even lower. Numbers a cardiologist would frame and hang on the wall. And the patient has been quietly experiencing every symptom on that list for months. The medical term for this is iatrogenic hypotension, which is a sophisticated way of saying the treatment caused the problem. These symptoms are routinely dismissed. Patients mention dizziness, told that's just part of getting older. Fatigue gets blamed on poor sleep. Cognitive slowness gets labeled as early dementia. Sometimes it is those things, but sometimes, more often than the medical system openly admits, it is a medication dose that is simply too high for that particular body at that particular age. You deserve to know the difference. In the next few minutes, I'm going to show you exactly how to find out at home today without any special equipment. This is something I walk every patient over 65 through in my practice. It takes 5 minutes, it costs nothing, and it can tell you more about your real cardiovascular risk than a standard office visit. It's called the orthostatic blood pressure test. Here is exactly how to do it. First, you'll need a home blood pressure monitor. If you don't have one, get one. For anyone over 60, it is not optional equipment. It is a basic health tool, like a thermometer. Step 1. Lie down flat on your bed or sofa. Rest quietly for 5 full minutes. Don't talk. Don't check your phone. Just rest. While you're lying down, take your blood pressure and write down both numbers. Step 2. Without sitting up first, go directly from lying to standing. Stand up as you normally would in the morning. Step 3. Immediately take your blood pressure again, within 60 seconds of standing. Write down both numbers. Step 4. Compare the two readings. Here's what you're looking for. If your systolic pressure, the top number, drops by more than 20 points when you stand, that is orthostatic hypotension. That is a red flag. A drop of 20 or more means your body is not compensating fast enough. That gap between lying pressure and standing pressure is the window during which you are at risk. Dizzy, unsteady, one unexpected step away from a fall. If you find this drop in yourself, do not simply accept it as normal. Write down the numbers. Take that piece of paper to your next doctor's appointment and put it on the table. That data matters. And I'll tell you exactly what to say when you get there, in just a moment. Let me give you the numbers clearly. This is information you should have written down and kept somewhere accessible. These ranges reflect current evidence-based thinking on blood pressure targets for older adults. They are not one-size-fits-all, but they are a far more accurate starting point than 120/80. If you are between 65 and 74 years old, a systolic pressure of 130 to 140 is generally the appropriate target range. This is already higher than the standard guideline, intentionally so. If you are between 75 and 84, the target shifts upward again. 135 to 145 is where the evidence suggests the best outcomes. Not 120, not 115, higher. If you are 85 or older, or if you have what doctors call frailty, meaning reduced muscle mass, a history of falls, or multiple chronic conditions, the appropriate range may be 140 to 150 systolic. I can already hear some of you saying, but my doctor told me anything above 130 is dangerous. I understand why that's confusing. The older guidelines were very aggressive about pushing numbers down. Some physicians trained on those guidelines haven't fully updated their approach. This is not about blaming your doctor. Most physicians are doing exactly what they were trained to do, but medicine evolves, and the evidence on blood pressure in older adults has shifted significantly in the last decade. One more thing I want to emphasize. These are population-level ranges. Your personal target should account for your specific history, kidney function, diabetes, previous strokes, current medications. This is exactly why the conversation with your doctor matters so much, which brings me to the next part. Most people leave their doctor's appointment having said maybe 30% of what they actually wanted to say. They feel rushed. They don't want to seem difficult. They assume the doctor knows best and leave it at that. I want to give you 3 specific questions to bring to your next appointment. Write these down. Question 1. Given my age, what is my individualized blood pressure target? And what is the evidence behind that specific number? Not, is my pressure okay? Not, should I change my medication? Ask for the specific target and the specific reasoning. A good physician will welcome that question. Question 2. Can we check for orthostatic hypotension at this visit, lying and standing? This test takes 3 minutes in a clinic. Many doctors don't do it routinely, but if you ask for it directly and by name, most will do it without hesitation. Question 3. Could any of my current symptoms, dizziness, fatigue, cognitive slowness, be related to my blood pressure medication dose? This opens the door. It gives your doctor permission to consider over-medication as a possibility, rather than defaulting to other explanations. You are not being difficult by asking these questions. You are being an informed patient, and informed patients get better care, every single time. I want to come back to that 28% statistic, because I don't think it is fully landed yet. 28% higher risk of serious falls and fractures in a population where a single fall can mean surgery, hospitalization, months of rehabilitation, or worse. We are talking about a risk increase that is not subtle. It is not a rounding error in a research paper. It is a clinically significant, life-altering difference. And in many cases, it is being created by the medication sitting in your cabinet right now. Here's what troubles me most after 30 years in cardiothoracic surgery. We spend enormous resources optimizing the number on a monitor, getting that systolic down to 118, hitting the guideline target, and we call that success. But nobody is measuring what happens at 6 a.m. when that perfectly medicated patient stands up in the dark and their brain doesn't get enough blood for 7 seconds. Nobody is tracking the slow, quiet cognitive erosion that happens when cerebral perfusion is chronically just slightly below what the brain needs to function at its best. The monitor shows a beautiful number. The patient is falling. The patient is foggy. The patient is slowly declining, and everyone is confused about why. This is the conversation medicine needs to have, loudly, openly, urgently, not just in academic journals, in every clinic, every pharmacy, every kitchen table where an older adult is taking their morning pills and wondering why they feel worse than they did 2 years ago. You may be one of those people, and if you are, what you've been feeling is not inevitable. It is not simply aging. It may be fixable, with a conversation, with a test, with a medication adjustment that takes 15 minutes to discuss and could change the next 10 years of your life. That is not a small thing. That is everything. Let's bring this together. I want you to leave with something concrete, not just information, but a plan. Here is what we covered today. The 120/80 standard was never designed for bodies over 75. It was built for middle-aged adults. Applying it universally to older adults is not evidence-based medicine. It is habit. The research is clear. For adults 65 to 74, 130 to 140. For 75 to 84, 135 to 145. For 85 and older, up to 150. These are not reckless numbers. They are protective ones. Aggressive blood pressure lowering in older adults increases fall risk by 28%. Falls at this age are not minor inconveniences. They are life-changing events, and they are preventable. Dizziness on standing, morning fatigue, cognitive fog, leg weakness. These may not be just part of getting older. They may be signs that your medication dose is too high for your body right now. And the orthostatic test, lying pressure versus standing pressure, is something you can do at home today. A drop of more than 20 points is a red flag that deserves a conversation. Here is your action plan. 3 steps this week. Step 1. Do the orthostatic test at home. Write down your numbers, both lying and standing. Step 2. Book an appointment with your doctor. Not in 3 months, soon. Bring your numbers. Bring the 3 questions from this video. Step 3. Advocate for yourself. You are not being difficult. You are being responsible. The best outcome for your health comes from a partnership between you and your physician, not from passively accepting whatever number appears on a prescription pad. Now, I want to hear from you. Have you ever felt dizzy when standing up and assumed it was just age? Has a doctor ever adjusted your blood pressure medication and you immediately felt better or worse? Tell me in the comments. Your experience may help someone else watching this make a decision that changes their life. And if this information was useful to you, share it. Send it to a parent, a sibling, a friend over 65. This is exactly the kind of conversation that doesn't happen enough, and it needs to. If you want to go deeper on cardiovascular health for older adults, subscribe and stay with me, because next week we're going to talk about something equally misunderstood: cholesterol targets after 75. And here's the thing, the guidelines may once again be getting it wrong for your age group. You won't want to miss that one. One last thing before I go. Everything I've shared today is based on current medical research and my clinical experience, but it is general information, not personal medical advice. Your situation is unique. Your history, your medications, your specific numbers, they all matter. Please use what you've learned here to have a better, more informed conversation with your own physician. They are your partner in this. Make sure they know you're paying attention. Take care of yourselves. I'm Dr. Julian Cross, and I'll see you next week.